Hi, everyone. Thank you so much for joining us for our Lucent Symposium. For those of you that are less familiar with Lucent, this is a new multidisciplinary primary care leadership program for both residents and faculty that's kicking off been going on at University of Chicago throughout the course of the year. This year, we're sponsoring a series of symposiums, and then we'll have a formal cohort that will be starting in July. Today, I'm excited to introduce Elizabeth Salisbury, who is currently the medical director at Heartland Health Outreach, a healthcare for the homeless provider in Chicago. Prior to this role, she was a medical director at the Behavioral Health Systems Baltimore, which is a quasi-public entity that oversees addiction services and mental health services in Baltimore City. She received her medical degree at Rush University, completed family medicine residency at University of Illinois Masonic, completed preventative health residency, and her master's of public health at Johns Hopkins. She has worked clinically in federally qualified health centers for the past 6 years. Thank you very much for joining us today.
So I will first just say that if anybody wants to scoot down, you're welcome. It feels really like a huge room to have everybody sitting so far away. I'll also say that, especially, I wasn't sure how big the group would be, but I think if we're this small, I'm really open to people asking questions as I go through. So if something doesn't make sense, I try not to include too many acronyms, but occasionally I mess up and have one or two, so let me know. Feel free to stop me whenever. I want this to be useful for everybody here. So I made this title and really regretted it because I realized about 5 minutes into trying to come up with an outline that it was way too broad. So I want to say also that I tried to think through what are some sort of basic categories of things that primary care docs or providers would need and want to know. But that being said, any one of these content areas could be an hour and a half or a day and a half long lecture in and of itself. So the things I'm going to try to get through today are first the epidemiology of opioid use and overdose in the U.S. And then I'll talk a little bit about identifying and addressing opioid use disorder in primary care settings. And finally, opioids in the context of chronic pain, which I know is everyone's favorite topic. And then I'll just try and give a few resources at the end of places you might want to look for further information. In terms of disclosures, I have no financial disclosures. I do always just like to give a little bit more on my background because I think that the lens through which I look at this issue might be a little bit different. So as mentioned, I'm a family doctor by training. Literally the night that I finished family medicine residency, I drove out to Baltimore to start preventive medicine residency. For people who aren't familiar, preventive medicine is public health for physicians. And I did that because I always knew I was really interested in public health issues. I think for anyone who works with vulnerable populations, you end up feeling like you're hitting your head against a wall a lot, not because the patients aren't doing their best and trying to do the things we're asking, but because the system around us is not good. And so I was really focused on trying to find a way to merge my clinical practice and public health practice. So I did this training program. And when I was at Hopkins and doing clinical work in the community, it just felt like everywhere I looked, I kept running into this issue of heroin because Baltimore is a heroin city. And so it didn't matter if it was a public health project I was working on, it didn't matter if it was in clinic, everything I ran into I kept bumping up into heroin. And I thought, well, okay, I guess that I need to learn more about heroin use. And I learned about it both from a public health standpoint, but also from a clinical standpoint. And really it became something I became really passionate about. And I just share that with you because I didn't go into medicine to do addiction, but it actually is the majority of my clinical practice now. And it was really out of need and demand that I saw in the community. I did just sit for my addiction boards in October, so if anybody wants to ask me about that or talk about that later, there's a sort of a pathway that's only available for a few more years where you actually don't have to do fellowship to sit for the board. So I'm happy to talk about that at the end if anybody has questions. And then finally, the other thing is that most of my clinical work has been in FQHC settings, so slightly different than working in an academic institution probably, so I've pretty much always focused my clinical work in federally qualified health centers. And then the last thing is that my last job, actually, I oversaw all of the publicly funded addiction treatment programs, so I really think about this issue from a systems perspective as well, so not just the clinical perspective, but how do we build better systems to meet people's needs. So that's a little bit about how I view this issue. So in terms of the epidemiology of opioid use and overdose in the U.S., historically, the leading cause of accidental overdose deaths in the U.S. was motor vehicle crashes, in adults, excuse me. So the leading cause of accidental deaths among adults in the U.S. was motor vehicle crashes. And for the first time ever, in 2009, drug overdose surpassed motor vehicle crashes. And it was really from sort of 2000 forward that this topic started to get additional attention, but I think really since this 2008-2009 time period that we started seeing a lot of increased focus and interest in this area. So the last slide was included all drug overdoses. So then you say, okay, well, what does that mean? Like, what are people actually dying of? So then you start to break it out and you look at all drug overdose deaths and opioid deaths, and you see that really pretty much 100% of the increase that we saw that from 2000 to 2014 was really due to opioids. And so the opioid overdose death rate has more than quadrupled in the last 15 years. So then you say, well, what does opioid overdose death mean? Because that's a really big category as well. So this data was really exciting. Because this is the first time this data has ever been released by the CDC at the national level, actually breaking this down into different types of opioids. So historically, it was kind of like heroin and everything else. And now we actually can see prescription opioids, so what we would sort of consider our standard pain pills that we prescribe in clinic, and then, which is the top line. You can see that there was this pretty steady incline, and then around 2010, 2011, a plateauing. Heroin, on the other hand, had been sort of pretty steady until 2010, and right around then we saw this big influx in the rate of heroin overdose deaths. And then the lines below that are, then methadone. Methadone deaths we've actually seen a decrease in, and methadone deaths are really tricky, and I'll talk about it a little bit later, but we have no way to parse out who's in methadone treatment. Was methadone prescribed in a pain clinic? Was it purchased on the street, which is what we saw most of the time in the Baltimore deaths that I reviewed? Was it most of the time the people dying from methadone had purchased methadone on the street, so we didn't even have any way to know where they got it from, but they weren't in methadone treatment and they weren't being prescribed methadone, but they somehow had methadone and that's what they died of? And then the last line on the bottom, let's see here. This one is fentanyl, and so, or is synthetic opioids excluding methadone, which this influx is actually pretty much all related to fentanyl. So for anyone who's listening to NPR recently, you've probably heard about some of the fentanyl overdoses on the East Coast, and we continue to see this rate increase, unfortunately. So why did we see this sharp increase in opioid overdose deaths, and particularly prescription overdose deaths between 2000 and 2014? And this association has been shown repeatedly, basically that the more opioids we prescribe, the more opioids in the community, and the more people die. It doesn't necessarily mean that the only people dying are the people who are getting the prescriptions, but as we sort of flood the market with these medications, the more and more people, they get into more and more people's hands, and more people die from overdose. And so this, you can see, as we started to have some of the plateauing effect, 2008, 2009 time period, we saw the same with prescription opioid overdose deaths. So again, I think particularly around 2008, when we saw that switch where the leading cause of death became drug overdose, there were a lot of jurisdictions, a lot of states, and even local health departments who took on various strategies to address opioid overdose. They've been done with varying rates of success, but I think that there are, again, particular states have done a really good job to address the prescription opioid epidemic. And so these interventions have included things like primary prevention, which would be education programs often targeting youth, safe opioid prescribing and disposal, so that's things like your prescription monitoring programs, drug take-back, provider education, and the regulation around pill mills. We haven't heard as much about this recently, but there was definitely a time period where there were Ohio, Kentucky, Florida, were like actually looking at where were there really large volumes of prescription opioids being written and going out and having like legal intervention. So actually looking to see if there were safe prescribing practices, arresting physicians, prosecuting, et cetera. Finally, abuse deterrent formulations. A lot of the states that went out, especially with sort of a legal eye to this issue, really were able to curtail the rates of prescribing and curtail the rates of opioid overdose. Unfortunately, some of those same areas saw really quick influx in heroin overdoses. And so this has been an area of a lot of controversy about sort of we need to be very thoughtful and think through what might the unintended consequences be of our actions. I will say it's still a bit of a controversy. I don't think that the entire sort of public health community necessarily attributes the increase in heroin to just these things. And I can talk more about that later if people are interested. But there's definitely a lot of anecdotal and some qualitative research, as well as some epidemiologic research that would suggest that that is the case. The last two, and I put them in bold, are opioid use disorder treatment and overdose response education and naloxone distribution. The reason I bolded them is because these are actually the two interventions that have the strongest evidence to work, to actually reduce opioid overdose. And sadly, these are the two that we've been sort of the slowest to pick up on. People may have seen or heard that President Obama announced maybe 2 weeks ago now that he was dedicating over $1 billion to these two strategies in particular. We know that these work. Opioid use disorder treatment, though, is expensive relative to some of the other things. So I think we've been a bit slower to pick up on it. But again, these are the two that actually have the best evidence. I already mentioned this a little bit, but this conversation about prescription opioids, and I'm not sure what this means, but I'm going to say okay. Prescription opioids and transitioning to heroin. So this is a great study. I would encourage people to read it if you haven't already in New England Journal, but looking at the relationship between non-medical use of prescription opioids and heroin use. And so basically they tried to answer this question of who are the people who transition to heroin use? Why do people transition? And did we cause some of this problem through our own public health interventions? And it was a literature review. And so one of the things that they found that I thought was particularly interesting is that present day, the majority of heroin users did initiate their opioid use with prescription opioids. Now, often it was for non-medical purposes, and they didn't really differentiate like what percent started with an acute injury and then progressed versus just buying it on the street the first time. They didn't differentiate that, but the majority of heroin users did start their opioid use with prescription opioids. But only a small percentage of people who are using prescription opioids for non-medical purposes do progress on to use heroin. So I think that's also important for us to keep in mind. So as we talk at the end about, people who are on really high doses of opioids, to keep it in context, you don't have to worry that like all of your patients who are getting Norcos are eventually going to move to heroin. At least at the national level, the rates are small, but they're definitely there. And so I think, again, it's really important for us as clinicians to think about how the choices we make in our prescribing practices and how we talk to patients about this could impact their trajectory. So I am now going to move on and talk about addressing opioid use disorder in primary care setting. If nobody has any questions on the first part. Yeah. Everything in the naloxone market has been changing, and I will be honest, I don't monitor the price of it as closely as I did when I worked in the public health sphere. So they just came out, it's now FDA, there's an FDA-approved device to be able to administer, are you going to get on here? To be able to administer naloxone intranasally, and that device is actually really reasonably priced. The naloxone that you get in the vial that you use with an IM syringe, the price of that had been steadily increasing even though it's been around for a long time. And then there's this new auto-injector that looks like an EpiPen and actually talks to you. I met the actual guy who developed it last week at the Addiction Medicine Conference. And the price of that's ridiculously high. like prohibitively, ridiculously high. The one thing I will say about naloxone in Illinois is that because of the Illinois Heroin Crisis Act that was just passed within the last like 4 or 5 months, Medicaid and Medicaid MCOs now have to cover at least one type of naloxone. So for your Medicaid insured patients, if you write a prescription for it, it should be covered, at least the IM version. So that's one step in the right direction. That was not always the case. But yeah, so and then I'm sure that every single company is going to be working just whichever formulation is the cheapest will be the one that's on formulary for that company. But yeah, it's been a bidding war. It's like everything else. It's a business, right? Like, take off the cap, like, put it on their leg, like, push the button. Like, I mean, it just, like, walks you through the steps. I think it's a nice idea. I mean, it's interesting. The naloxone literature is really interesting. We mostly just give out syringes. I have one in my backpack if anybody wants to look at it, because I go into shelters some still, so I usually carry it. But drug users, the evidence has shown that the best people, like if you want to get the most bang for your buck from a public health perspective, you should give Narcan to drug users. They're the most likely to use it. They don't really need any training on it. They're very comfortable with needles, and they're gonna be the people in the settings to give it to their friends. So I think that this auto-injector is really nice actually for family members who don't feel comfortable with needles, who might get squeamish at the idea, and it like literally walks you through it. But yeah, the evidence is pretty clear, particularly around cost effectiveness. If you want to have a cost effective strategy, you just give the stuff to the drug users and they'll figure it out. And we know we've been doing trainings at my organization for like 1.5 years now, I guess. Understanding order under my license, which is something else I'm happy to talk about for people who work in community-based programs, something that I would definitely recommend everyone to consider. And we've had multiple reversals reported just back to us, and I mean, we're a really small organization, so drug users are really pretty savvy with it. It's kind of the other groups that you need to think about what's going to be the right fit for them. Any other questions? Yeah. So again, I used to follow this a little bit more closely when I was in Baltimore and in a more public health sphere. I haven't looked at recent, like, sort of where we're expecting the drugs come from. I mean, I will say that heroin purity in Chicago seems to be pretty high right now. Where it's coming from, I apologize, I haven't had a lot of focus on that in recent months or years.
I can tell you that the source was from a person who's in the heroin business, so it may not be called out.
Yeah. Well, and a lot of times, I mean, the DEA does. I mean, there are reports, and I should remember what these are called. But I mean, so Baltimore and DC, one of the reasons why it's such a problem there are a lot of reasons, but is actually where a lot of the drugs come in, and so it tends to be the purest. And then as you go further across the country, it becomes less and less pure. It was really interesting because when I was in Chicago before, I used to volunteer with Chicago Recovery Alliance, and at least maybe I had a skewed view, but everyone that I met here always injected. And then when I moved to Baltimore, I would meet people who said they only snorted, and I was like, yeah, right, like, people don't do that. And they're like, no, like, half the people in Baltimore only snort. Like, that's what we do because it's really pure and we can. And that wasn't something I'd experienced here. Now, I'll say since coming back, I do meet more patients now who are in addiction treatment who at least report only snorting and never having injected. So it is interesting, but you'll see different trends across the country based on the purity of heroin as well, so. Okay, I guess that this is okay. So just put that down there. So I'm going to talk now about identifying and addressing opioid use disorder in primary care setting. So this is not easy, and I definitely will admit that I oversimplified it. But again, I just wanted to talk about a few things, sort of food for thought of things that you might be able to implement in your own practices if you haven't already. So out of curiosity, are people using, how many people here are in outpatient care in general? Okay. So are people using SBIRT in their clinical practices? Have people heard of SBIRT? Okay, great. So screening, brief intervention, and referral to treatment. I'm not going to spend a lot of time on it. I will just say a couple of things. First is that there's a big push toward this right now. We actually just got a grant from HRSA that like one of the requirements to even apply for the grant is that you would promise to implement SBIRT as part of the grant. So it's really being very strongly almost required in some settings. But it's interesting because the initial research was done in ER settings and focused on alcohol use. And when you try to look for outcomes research in primary care settings and also including drug use, we don't have a lot. It's a little bit, and it's kind of variable. It's nothing that I would get like super excited about as like this super promising practice. I do think, though, that it's just sort of this recognition that there's something that we should be thinking about, and even though we may not catch it often, when we do, it could be very life-changing for people. But I do think it's just important to know that there's not a ton of evidence focusing on primary care and including drug use, even though everybody's encouraging us to do it that way now. So basically, SBIRT, you would have a validated screening tool for drug use. The DAST is the one that's commonly used, much like you would use like a PHQ-2 in the clinical setting for depression. You would have a one-question screener that asks, and I should have written it down, something like, in the last 12 months, have you used any illicit substances or prescription medications for non-medical purposes, or something like that. It's a little more patient-friendly than that. And if the answer is yes, then you fill out a longer questionnaire, much like the PHQ-2 and the PHQ-9. And depending on the score here, you would then either have no intervention if your answer was no, or a brief intervention, like, wow, I'm really worried about your drug use. Can we talk about, X, Y, and Z? An extended brief intervention, which would often be done by a social worker, or another sort of behavioral health person in your setting, and or referral to treatment, depending on the score that you got from the previous screener. So I just like to bring that up. I do think that it's something we're going to see more and more of, and it's probably something that's going to become standard of care, even though the evidence is sort of lacking. It's not that it's bad evidence, there's just not a lot of it. So if you're not using SBIRT in your clinical setting, I just wanted to review a couple of things that may make you want to sort of think about asking questions about substance uses. So first are psychosocial indicators, and these are hard if you're meeting someone for the first time. So I'll just say that because you don't really have a baseline with which to compare it to. But things like, mood changes, agitation, mood swings, anxiety, relationship problems, marital problems, friendships, social isolation, problems at work, missing work and school, legal problems, and, new debt, so recent financial problems. In terms of physical indications, these are really specific to IV drug users, but track mark scars, abscesses, skin necrosis, allergic reactions. Other things, requests for medications in higher volumes than you would expect for a given injury or setting. So someone who broke their leg a year ago and they still need 4 Norcos a day, like things that just that seem sort of out of context. Definitely seeing multiple prescribers in the PMP is something that you would want to be have your sort of concern raised. And then physical signs of chronic opioid use, I'm sure people are already familiar with just from working with patients with pain. And then physical signs of withdrawal. I've seen this more than I would like to admit, where people come in like, oh, I'm in so much pain, and they're like physically like jumping all over the room and sweating and just super uncomfortable. Sometimes they're nauseated. A lot of agitation are all signs of physical withdrawal, and we will occasionally have people come in, really saying that I need my Norcos right now for this, and you can just look at them and tell that they are starting to withdraw from some form of opioids. I always like to bring up the changes in diagnostic criteria from DSM-4 to DSM-5 because I think particularly the language is really important. And I think it also is a reframing of the way that we think about addiction. So DSM-4 had 2 terms, dependence and abuse. Dependence had 7 symptoms and abuse had 4, and they were these separate diagnoses. And now in DSM-5, we've moved to the term use disorder, so it could be alcohol use disorder, opioid use disorder, et cetera. And it's considered a spectrum disorder that ranges from mild to severe, and it's based on the number of positive symptoms the person has. So they literally took the 11 symptoms that we had previously. They're now all part of a single use disorder, but they switched one out. And so the legal problems that was a previous diagnostic criterion for dependence, or I'm sorry, for abuse, they took that one away and added in cravings. So that was the sort of clinical change. And I listed out DSM-5. I'm not going to go through them because you can easily look them up. But I did just want to point out one thing, and that is that number 10 and number 11 are tolerance and withdrawal. And this is really important because these are natural physiologic responses to being on opioids for any extended period of time. So if the only two symptoms that a person has are tolerance and withdrawal symptoms when they aren't taking the drug or the medication, they do not, as long as they're taking opioids under appropriate medical supervision, so basically taking the medication as prescribed by their provider, they do not meet criteria for opioid use disorder if those are the only two symptoms. If they have those two symptoms plus a bunch of others, then they absolutely meet criteria. Or if they're, buying their pain pills on the street and they have tolerance and withdrawal, it would still technically qualify as like a mild opioid use disorder, as just having two positive symptoms. Any questions about that? Okay. So the reason I always bring it up is because does language matter? And I would argue that I think it really does. If you think about the word abuse, just by itself, it's not a very positive word. It definitely, I think this transition of the term abuse into use disorder sort of starts to really medicalize the diagnosis. And as we've learned a lot more about addiction, the neurobiology of it, the genetic predisposition for it, we've really come to understand that it is a chronic disease, and it really is a spectrum disorder. So there is a wide range within it, much like many other mental health diagnoses. And so I would just encourage everyone in this room to really work hard at trying to use the DSM-5 terms and try to get away from the word abuse. And you'll also see, particularly in recent literature, this moving away from the term of misuse and now using the term non-medical use. It's hard to say. You may hear me fumbling over it still. But again, this idea that these have really negative connotations and we really need to start treating these as medical diagnoses if we're going to be able to move forward in terms of treatment. So opioid use disorder is a chronic disease. I already mentioned this a little bit, but we know now that there is a large genetic component. We think about 50% of the risk for opioid use disorder is genetic. It's been linked to various genes depending on what the substance is that we're talking about. We also know that there's an environmental and behavioral component. So when I talk to patients and their families, a lot of times I talk about comparing it to like type 2 diabetes. So people with type 2 diabetes, if they come in my office and they have an A1C of like 8 or 9, early diagnosis, usually there's somebody in their family that has diabetes. And usually, if I told them, okay, I want you to spend the next year losing 50 pounds, change your diet entirely, carb count every meal, and you may not need medicine, that's very true. And the treatments that we use for diabetes and hypertension would also include behavioral interventions as well as medications. And we're moving very much into a world where opioid use disorder should be viewed in the exact same way. This is a chronic disease with a large genetic component. Yes, there are absolutely environmental cues and behavioral components, and that our treatments should encompass both medication as well as behavioral intervention the same way that we view other chronic diseases. And it's not like a once and done, you're cured, good luck with the rest of your life kind of deal, that it's something that you will continue to deal with your entire life, and we as your primary care provider are going to continue to work on it with you. So similarly, in the substance use disorder treatment, we're moving from a very acute care model, this idea that someone goes to treatment, they get an assessment, they get a treatment, and they're discharged, and they're done, to really this chronic care model of implementing primary prevention, but also early intervention, screenings, things like SBIRT, treatment, and then this lifelong sort of recovery support services. I think for people who work particularly in the legal system, this is a challenging thought because they want to say like, well, we sent them to treatment and like they should be good now, they're done. And it feels very finite, and it's also cheaper when you do it that way. But this idea that people are likely to have relapses, for anybody who's ever worked with people who smoke. I mean, there are going to be times when people start smoking again, and you're going to work with them again, and they may quit again, and this could be a lifelong sort of struggle. And that's what we come to expect, the same way that people may have periods when their A1C is better controlled and periods when their A1C is less well controlled, and we don't kick them out of our office because they aren't taking their insulin properly. So I would really encourage people to also think about this as a chronic disease when you're approaching these folks. I do realize, in working with my own team of providers, that it's a little bit more challenging because aberrant behavior is sometimes part of the disease, and that makes it challenging sometimes for us as clinicians to develop this therapeutic sort of relationship. And so every time someone comes to me like, but I know he's lying, and I'm like, and it's a symptom of the disease. So try and really reframe it that it's nothing against you, that it is a symptom of the disease, and it's something that we are working with someone on to develop this relationship, and there's so much shame and so much stigma around this disease that a lot of times that's playing into why patients are doing the things that they do. I always talk a little bit about what substance use disorder treatment looks like because I actually think that at least I didn't learn almost anything about it going through medical school or residency, and I think maybe we know what we see in the movies or maybe what a patient told us once, but don't really have a good sense for what addiction treatment services look like in the US, and so I just like to walk people through it a little bit. So there are levels of care, and they should be based on the severity of disease and the psychosocial situation. And the levels of care can vary anywhere from 2 hours a week to very intensive, like inpatient programs. And so, I mean, you could really liken this to like a primary care clinic versus an ICU stay. And so there's this whole sort of various levels of care in between that. And the different levels of care may or may not include medications, which we'll talk about in just a second. So there is an assessment tool, and I just want to say I'm telling people this because I think it may help us in how we sort of direct patients, not that I expect anybody in this room to use this tool, but I think it's important for when we encourage someone to, quote, go to treatment, to have an understanding of what that is. So the ASAM stands for the American Society of Addiction Medicine, and they developed this treatment criteria to help identify where, like, what level of care people most need. This is an evidence-based, validated tool that we know if someone scores into basically a very high level of care and they opt to go to a lower level of care for whatever reason, they're going to have worse outcomes. But if they score into a low level of care but decide like they just need a break or whatever, have some money to burn, and they want to go to a 28-day stay just because, that they don't have better outcomes. So basically, just if you follow what the assessment says, that people are optimized to have the best outcomes, and if you go to a higher level than necessary, you don't necessarily do better. The dimensions include the things listed here: acute intoxication, biomedical conditions, emotional behavioral, cognitive conditions, readiness to change, relapse, continued use or continued problem potential, and finally recovery and living environment. These are the levels of care. So outpatient services, this is usually just like a couple hours a week. Intensive outpatient, or people often refer to it as IOP, this is usually where somebody goes every single day for at least a couple hours and is doing either groups or individual therapy. Residential programs range from being like a recovery stable living environment where there's sort of staff available but you're doing your own thing on the day-to-day, versus a 28-day stay, which is very much like intense all the time. When you're awake, you're on a rigid schedule with everybody else on your unit, and you are going to treatment groups pretty much all day long. And then level 3.7 and 4 are usually like really intensive people with medical conditions. Level 4 is hospital-based. Level 3.7 a lot of times is like a detox program, a 5 to 7 day medical detox. I always like to throw in that medical detox is not treatment. I think it's really important. Again, a lot of politicians like detox, a lot of judges like detox. I think that historically people liked this idea of we were going to send somebody to detox and then they would be off drugs and it would be great and they would be done. And so I would, again, sort of liken that to like an ICU stay for DKA. Can you imagine if like that was your full treatment? Like, oh, well, you didn't listen to us when you were in the ICU and we told you how to take your insulin? We gave you all that great education. The nutritionist came, you're done. Detox is like just the safety part. So medical detox safely detoxes someone from drugs, usually alcohol or opioids. And that's it. Like, no, you really don't have the opportunity because you're too physically uncomfortable to learn coping skills, to really think about what your recovery is going to look like. And so one of the worst things, in my opinion, that we can do for people is send them to opioid detox and not link them to the next level of care. And this happens all the time. In terms of state funding, and Illinois is not alone, we love to fund detox, but we don't like to fund longer levels of care because it's expensive and it's long. And so people may finish, and even if they're willing to go to the next level of care, we don't have a bed for them at whatever that next level of care may be. And what actually happens is that now we've taken you off of your substance, and if you go back out tomorrow and use at the same level you were using a week or two ago, you're actually at much higher risk for overdose. So we're actually sometimes putting people in more harm's way than we are helping them. So I just like to throw that out there in terms of, again, what we recommend for patients, or if we're working with someone in terms of recommending something. I'm not saying detox is bad. Sometimes it's necessary, especially for alcohol use. It's often necessary, but that is not treatment. And so being very thoughtful about what we recommend and how we get people there. ASAM levels of care, so I already talked about this. So MAT has been in the news a lot lately, so medication-assisted treatment for opioid use disorder. I will just say that there is MAT available for alcohol. Unfortunately, we don't have a lot of meds available for other substances. But for opioid use disorder, we have a really long track record with a lot of evidence around how effective MAT is for opioid use disorder. So there are 3 medications that are currently FDA approved. The first is methadone. It's a full opioid agonist, which means that the way the brain views the drug is very similar to the way it views prescription opioids or other prescription opioids, I should say, or heroin. So if you take too much of it, you can overdose. It has been available since the 1970s. And in the United States, a patient is only able to receive methadone for opioid use disorder in a methadone maintenance program. So no one in this room, it would be illegal for anyone in this room to prescribe methadone for opioid use disorder. We can prescribe it for pain, but it is not recommended or it is not legally allowed to be prescribed from any setting other than a methadone maintenance treatment program. There are a lot of strict regulations around it. So if you've had patients in methadone programs before, you may have heard them talking about dailies or take-homes. So for the first 3 months, legally, people have to get their dosing there daily, which is really challenging for folks who might still be working. So, if you have to go there every day to get your daily pickup or else you get sick, and that means that you're going to work late, that's a really hard decision. So I think some of the on the flip side, I would say that for some people who need a lot of structure, who maybe don't have a lot of things to do during the day, or all of their old daily behaviors are not the behaviors you want them to be having while they're in recovery, methadone maintenance can actually be a really great thing, because then they have a place to go every day. They have a new community of people who are also in recovery. So it can have a positive effect as well, but it's just something to be aware of. There's really strong evidence around methadone maintenance treatment. So I should also mention that these are called medication-assisted treatment because these are never meant to be used alone. These are always to be used in conjunction with therapy and some behavioral component. I'll talk a little bit more about the evidence specifically in a couple of slides. So buprenorphine is the second medication. The other trade names are Suboxone or Subutex. These are partial opioid agonists. So what that means is that they are going to have a ceiling effect. So you can take more and more and more of it, but at some point it just levels off, which makes it a lot safer in terms of overdose risk potential. The ability to overdose on it is really, it's actually really hard to do unless you're either completely opioid naive, so like a child who took this medication could potentially overdose on it, or someone is just mixing a ton of substances together, so like buprenorphine plus alcohol plus benzos plus maybe some other stuff. Particularly respiratory depressants are the ones that you're going to worry about. It's been FDA approved since 2002 and can be prescribed in outpatient settings with a data waiver. So this is like an 8-hour training program that physicians, and right now it's unfortunately only physicians, can go through to get this additional sort of license to be able to prescribe it. There is also strong evidence around buprenorphine, again in combination with behavioral therapy, around retention and reduction in drug use. And then finally, the newest drug to the market is naltrexone or Vivitrol. This is an IM depot injection that lasts for about a month, and it actually works the complete opposite way. So it just goes to the brain, blocks those receptors down so that for the next month, no matter what you take, methadone, heroin, Norco, it doesn't matter, there will be no effect. So it does prevent overdose, at least while the shot is in your body. And it's been FDA approved since 2010. In terms of a treatment option for opioid use disorder, it has been shown to be better than placebo, but when you compare, and there have been no head-to-head trials, but when you actually compare the evidence to buprenorphine or methadone, it's really lacking. So what I would say is that I think that there may be populations that could really benefit from this. Definitely people who are adamantly opposed to using any kind of other medication would be a good one. Like I have a patient who really, it's like he really wants to be a bus driver, and you can't do the DOT exam if you're on methadone or buprenorphine. And so that's what his long-term goal is, and so he might be a good candidate for this medication. Also, like physicians and pilots, people who can't, who absolutely aren't supposed to be on the other two medications or who can't take any risk for increased sedation, they might be good candidates for this drug. So, so I wouldn't recommend it personally as a first-line medication just by looking sheerly at the evidence, but I think that it's still something that, you know, is newer. We're still waiting for more evidence, and there may be populations that are good fits for it. So I already talked about this a little bit. Again, just that methadone's a full agonist, so there is risk for respiratory depression to the level causing death, and then that buprenorphine is a partial agonist. I should also mention that when someone's in a methadone treatment program, there's a lot of regulation around starting dose. So, and they make you taper up from a pretty low starting dose. And so that's how they've really tried to regulate and make sure that people aren't overdosing. When I was in Baltimore, I reviewed all the overdose deaths for the city, and we never saw a single, we saw methadone deaths, but we never saw a single methadone death for a patient who was in a methadone treatment program. And so I think that's just important to keep in mind, that this drug is absolutely used for non-medical purposes. And we also know that there are sometimes deaths for people who are receiving methadone for pain, for reasons of pain. So I just wanted to share that. But I do think it's important to think about when you're giving people additional medications who are on methadone maintenance. So, indications for medication. All patients with opioid use disorder should be offered medicine. I think it's important to know that only about 10% of people with opioid use disorder who are in addiction treatment actually get medication. So if this was any other disease, this would be outrageous and totally not allowable. So that only 10% of the people with the disease are not getting the treatment that has the best outcome. And the treatment is not even very expensive. Again, I think this speaks to some of the stigma around it. It's really interesting. Many addiction treatment programs, especially if they don't have like a medical detox or they're not a methadone program, they may not have any physician that works with them at all. And so there's really not even an option for them to give medication. There's also a lot of historical stigma, even within the addiction community, around using medications at all. That people may be cheating, that they're not really compliant with the 12 steps. So these are conversations that people have, and so I think this is another area where if we're working with patients who maybe are in a program, they're not on medication, and they're not having great success, that maybe encouraging them to find a program where they could get access to medication would be a good choice. Factors to keep in mind. So again, if you were trying to help somebody, the other problem is that there really is no single program you can go to and learn about all the options because nobody does them all. So if you're a methadone program, you usually do just methadone. If you're a Suboxone provider, you legally can't provide methadone as well because you're likely in an outpatient setting and you're not a methadone clinic. Again, Vivitrol is newer, or naltrexone is newer to the market, so that one you may see sort of sprinkled here and there, but it's the same thing with levels of care. You came here, so I'm going to offer you what I have, even though maybe you would do better if you got something else. And this is sort of the disorganization that happens in addiction because every treatment program is sort of very siloed and not connected. So again, I think as primary care providers, it's important for us to know that and help people think through what might be the best option for them. So in terms of treatment effectiveness, the goal of treatment is to return to productive functioning. And we know that particularly methadone and buprenorphine reduce drug use by 40 to 60%. And sometimes people say 40 to 60%, that sounds terrible. But if you actually think about what percentage of our patients get their blood pressure below 140/90, or what percentage of our patients actually get their A1C, you know, in that around 7 range, it's not that different. And in fact, the rates are actually really comparable. And the strongest predictor of recovery is retention in treatment. So a lot of times it's just getting that person to engage or re-engage in treatment. And yeah, there may be slip-ups, but again, continuing to sort of go back and continue to work on it the same way we would if somebody's A1C bumped up for a while. We would still work with them to try and get it back down. In terms of benefits of treatment, a lot of the literature around this is really from the methadone literature, but it's been shown to reduce, and that's because it's been around the longest, it's been shown to reduce risk of HIV and Hep C transmission, reduce risk of overdose, death, reduce crime rates, reduce, and it increases rates of employment and increases length of life. So I'm looking at the time, and I'm taking way longer than I had anticipated. So I will just finish up these last couple slides. So how long is treatment needed? So definitely it's individualized, and I think this is one other thing that's really important for primary care docs to know. So I often hear people complain that, like, my patient is on methadone, and she's been on methadone for way too long. And I'm like, okay, like, what does that mean? Why do you feel that way? I don't know. Well, they should taper her off by now. She seems fine to me. And so, again, I kind of take it back to the diabetes conversation, and it's really funny. I had a patient come to me once, and he was starting buprenorphine, and he said, he's like 55, and he said, you know, my mother wants to talk to you. And I thought, you're 55 years old, like, what are you, and, you know, and he's like, she doesn't want me to be on this medicine anymore. She wants to talk to you, and she wants you to tell her when you're going to take me off of it. And I was like, well, okay, that's fine, let's talk to your mom. So we call her. And I said, you know, how many people in your family have diabetes? And she was like, oh, you know, like all of them. And I was like, okay, so, you know, when do you tell your family members that they can't take their diabetes medication, that they should just lose weight? She was like, well, no. And I was like, okay. I was like, do you tell them they should just change their diet? And she's like, well, no. And I was like, okay, well, we need to look at this the same way. I said, there will hopefully be a day when he is so stable that we can start to have that conversation about tapering. That day is not today. He's been on the medicine for 2 months. And so, you know, we will continue to work on it. We'll continue to assess it and readdress it, but I can't tell you when they're going to be done. There's really not a lot of great evidence around when to taper, other than sort of going back to that initial assessment and saying, like, okay, is this part of your life stable? Are you in a stable living environment? Do you have friends who don't use drugs? You know, is your work environment stable? Because all of those things can be relapse triggers for people. We know that the longer someone's on treatment, the less their likelihood is of relapse. So for me, again, if keeping this in a chronic disease model, it's not my motivation to get people off as quick as physically possible, because what we see is that so often when we get people off too soon is that they relapse. So it's really about working with people, meeting them where they are, and letting them go slowly when they are ready to taper. And then a lot of times I have people start to taper down, and they're like, oh, no, like, this isn't, like, never mind, I'm thinking about it every day, or maybe they have a relapse, and then we increase the dose again. So I think it's really important for us to know that it is individualized. If it's allowing people to be functional and work, participate in society, have relationships with their family and loved ones, is it a big deal if they're on medication long term? I would argue that it's not, if people are doing well. So I don't push people to get off the medication until they're ready. We know that less than 90 days in any treatment setting is of limited to no effectiveness. And studies have demonstrated that MAT, so medication plus therapy, has superior outcomes as compared to therapy alone. So it's 5 o'clock. I have a ton more slides, an embarrassing number of slides. I can go on and talk about opioids in the context of chronic pain. Really what I did here is just so people know, I don't know, have people seen the CDC guidelines that just came out? So basically, I worked with, I co-presented with CDC at ACPM like 2 months ago, and so I asked them, did they have any slides they could share with me for this presentation today? And so they just sent them. They're going to be publicly available in like a week or two. So I'm happy to go through them if people want me to like push through. I just feel like I've been talking for a long time. So if people want to ask questions or have a conversation or discussion, I'm happy to do that as well. Silence. So let me ask it a different way. Any questions? Do people want to hear these slides, or do people just want to go home because it's 5 o'clock? Mm-hmm.
How do you do that? What kind of resources are there in Illinois?
Yeah, it's a problem. So I was pretty appalled when I moved back at how disorganized our system is here. A lot of it is probably working with social workers, getting to know your community, figuring out who the programs are. I know who the programs are around us, and I've developed relationships with them, but it's tricky. So in an ideal world, you would have a centralized intake, like this is what we had in Baltimore, centralized intake, where anyone could call and say, they would do a really brief assessment over the phone and try to do a basic identification of we think you need this level of care, and then actually make your intake appointment for you. Here it's really messy. I mean, you can Google and find you can find on IDPH or on the DASA website, a list of all the methadone treatment programs, but sometimes they've closed, sometimes they're pay out of pocket, figuring out which one takes which insurance. I'm very hopeful that in the near future, particularly around opioid use disorders, so the other thing that changed is through the Illinois Heroin Crisis Act required that Medicaid covers methadone. So historically in Illinois, methadone was covered through DASA. So you didn't get methadone through your Medicaid. Either you got a slot that was paid for by DASA, or you paid out of pocket. Those were your options. So that's all changing right now as I speak. So I'm hopeful that in the near future that you could call the MCO and say, which methadone programs do you work with? And then they could help you actually identify the right program. The same goes for buprenorphine treatment. I've actually been trying to do that some just to see, and I haven't gotten any traction yet, but the law just passed very recently, so that, I think if we give it a little bit more time. Sometimes the MCOs do have care coordinators that can help. If you have a sense of what you think your patient wants or needs, you could say, okay, I need help getting access to this thing, and really kind of putting it back on the MCO because it is what they're supposed to be doing. So yeah, it's tricky. And then I think knowing your community, knowing the programs that are available in your community and the types of services that they offer. The other thing is, again, drug users are so savvy and they talk all the time. So a lot of times if you're like, do you know where they'll for sure know where they don't want to go because they've probably already been to that one. And they'll often know, well, I heard a good thing about this one, and then sometimes you can help them navigate that system. I would just say, so I work right now pretty much only with homeless population. People who are experiencing homelessness almost always qualify for residential stays. So, definitely if they're willing, the problem that we have a lot is that people don't want a residential stay, and they often don't do well in outpatient, but we still, work with them to give it a shot. So I think trying to figure out what they want, what level of treatment. You can still call DASA, but poor DASA, their funding has just been cut like every which way. So I'm sort of starting to lose faith that, they're going to have a lot of coordination efforts to be able to help. We're in a tight place right now in Illinois. The city health department, I work with them some sort of in an advocacy free consultant role. And they are working to try and better coordinate services, at least get like sort of a map of like where services are available. I've been talking to them about developing that intake line like we had in Baltimore, and something that they're definitely exploring. I think they definitely realize how disorganized things are, and so they're working on it. But I don't have like an easy call this phone number answer for you. Yeah.
Really nice presentation, and you'll check out the CDC slides. What about becoming a Suboxone?
I'm so glad you asked. This is always one of the things I try. So becoming a prescriber is really easy. It's 8 hours. You get CME for it. It costs like $250, although occasionally there will be like these grants and then it's free for a little while. I am biased, but I really believe that it fits really nicely into primary care settings. Not by itself, not as a single physician being the only one there doing Suboxone. But I think that if you can build a little bit of a system around it with some type of like licensed social worker, maybe a CADC, and have a team model actually working around this, I think it fits into primary care really nicely. The thing is, whether or not we know it or whether or not we've identified it, these patients are already in our practices. So it's just a matter of providing more holistic care to them. And so, like, I was in clinic yesterday, and pretty much my clinic is all, everyone in the clinic that I see now is pretty much on buprenorphine, but these people come every single week, and then as they start doing better and become more stable, every single month. What other patient do you have where you actually can talk to them about their blood pressure, their weight? They actually come every single month. And I do work with a very vulnerable population, so that's just not our common thing that we see. But they're very motivated to come because of the medication. It fits into the practice really nicely. I think that you do need support around doing it. So again, being one doc doing it alone, because if people don't get their medicine, like you go on FMLA or you go on vacation and there's nobody else to prescribe, they'll get really sick and probably relapse. And so you do need a system in place around it, but there's tons of information out there on how to build the system, and it's not that hard. And I do think that it's a service that people really, really appreciate, and it fits really nicely in the primary care model, especially with all of the increased focus on integration of behavioral health right now, and the team-based approach that we're all either doing or working toward. We have team-based care meetings once a week, where we have an LCPC and a CADC and a recovery coach all as part of the team. They do a lot of the legwork. They do the weekly check-ins. They call people. They do the therapy. We make sure that we get lists for people to go to NA and AA meetings outside of our office setting. We sometimes coordinate with other drug treatment centers if they're in OP or IOP in addition to what they're doing with us. So they manage all of that, and I really just manage the medicine, plus the other primary care stuff, which is usually a lot. So it's a great model. It's something that I would really encourage everybody to consider. And I do think that it's something that we're going to be seeing more and more of. Again, there's just been so much focus on it recently at the national level, trying to get more people to do it. Anything else? Yeah.
This is mostly just for people who are abusing heroin. 'Cause I have a patient that was using opioids for chronic pain, so not using them not for non-medical reasons, but like as soon as I met him, I felt like he had this dependence. And I talked to him about seeing there are these programs available, and basically he actually went to some of them, and they all told him he didn't qualify.
It's really tricky. So, so right now, if you go to a substance use disorder treatment program and you say you have chronic pain, they're going to be like, oh, you shouldn't come here because we don't know what to do with you. It's basically, I mean, they're not going to use those words, but that's how it's going to be. And if you go to a pain specialist and you have a strong history of addiction, which it sounds like your person doesn't, they also get very uncomfortable. There are national experts who focus sort of on this intersection. Buprenorphine is not FDA approved for pain, but there are people who run clinics for people with chronic pain and, wow, this screen is like going crazy, with chronic pain and histories of addiction, or possibly it gets really fuzzy when people are really like just walking the line of this overlap. Where they may have some criteria for opioid use disorder, but they do have chronic pain syndrome as well. We do know that buprenorphine helps with pain because it is still attaching to the same receptors in the brain. So I do think that you could definitely try it with people. I think it would be important to be clear that it's not FDA approved for pain, but we know it can help with pain. But it's tricky. The other thing I should say about getting your buprenorphine waiver is that there are mentorship programs across the country where you can sign up to be matched with a mentor, so that when these really difficult conversations and situations come up, that you can then work with somebody who's been doing it for much longer. It's interesting, I mean, in Baltimore, the system had been in place for like 10 years. Like every single federally qualified health center in Baltimore prescribes buprenorphine. There are clinics that have a rule that to work in their federally qualified health center, you have to get your buprenorphine waiver and prescribe. Like the problem there is more pervasive, but they've just really institutionalized it. All of the major academic centers have programs. All of the major hospitals have programs. Like it's just a totally different world, and I came back and I was like, one, heroin isn't as much of a problem here, or historically hadn't been, but there's just really, it just feels like it's, we're really behind the times in Illinois. I was at the Addiction Medicine Conference last week, and there were people in West Virginia who had better access, like getting people better access than we do. And like I had a pregnant patient who really was adamantly opposed to taking methadone. I called every MCH department, every academic MCH department I could find, asking if they would take a patient on Subutex and co-manage with me, and every single one said no. And again, I'm finding these OBs in rural areas at the Addiction Medicine Conference who are doing it. I mean, we are so far behind here. It's really sad, for lack of a better word. Now, granted, some of these communities have been hit so hard, particularly in the Appalachia region, by the prescription opioid problem, that they were sort of forced into it. But I think that we really need to step up in Chicago, to be really honest, which is why right when I got back, I started talking to the city, I started talking to DASA. I was like, what's going on? Like, why aren't we doing anything? And I mean, the city health department here doesn't have a division to focus on addiction. In Baltimore, we had an entire 50-person agency. So I mean, it just kind of speaks to the differences in the focus, and we're funded a lot less here in the Chicago City Department of Public Health. They don't have the same budget that Baltimore did, but yeah, we're really behind. They are working on it. They're hiring a position, a director of behavioral health, that would oversee this and really develop their first strategy, but we're really pretty behind. in Chicago and in Illinois. And I'm from downstate, and so if you want to talk about limited access to treatment, go 4 hours south. There's really limited access to treatment there. So, one other thing that is in the next set of slides that I will just bring up is, I don't know if people prescribe naloxone, but one of the recommendations from the CDC, and the really sad thing about all of these guidelines is that they have really limited evidence base, but is this idea of co-prescribing. So when you're prescribing opioids at higher than 50 morphine milligram equivalents, that you would co-prescribe naloxone. And that is something that we do in my clinic, and it's something that I would strongly encourage people to consider because it's easy, it's really safe, it's now covered by Medicaid. I don't see a lot of reason not to do it. So I would really strongly encourage people to consider that as well in terms of just something that's easy to implement into your everyday practice if you even have many patients that are on more than 50 morphine milligram equivalents a day. So I'm trying to think. Yeah, there's way too many things to go any further. So any other questions? Otherwise, I'm happy to stay behind for a few minutes in case anybody wants to talk. All right, thanks.